One, do you
Hello.
hear me?
Yes, you are audible.
My screen show to you, everyone.
Is it? It is visible. Yes, you can start.
I'm Hussein Jaafar from Sudan, University of Khartoum, Faculty of Medicine. First, I would like to thank the organization committee of the conference, and I will want to thank all the participants for the highly scientific content of their presentation. I will present olfactory bulb changes on brain MRI in an adult patient with anosmia due to COVID-19. The systematic review. Coronavirus are important human and animal pathogens. It's a novel, as we know, novel coronavirus name SARS-CoV-2 was first isolated in a cluster of patients with pneumonia in Wuhan toward the end of 2019. Then the World Health Organization called the disease caused by this virus coronavirus. Uh, in February 2020, SARS-CoV-2 is belong to coronavirus family, which also includes SARS-CoV and MERS-CoV that appeared in 2003 and 2012 respectively. COVID-19 presented with various symptoms, respiratory symptoms, GI, neurological and other symptoms, but the classical symptoms are fever, fatigue, and cough. Anosmia or loss of smell sensation is now becoming a frequent symptoms in COVID-19, which can occur alone or associated with loss of taste sensation. It can be tested clinically using olfactory tests like alcohol sniffing test. This is reliable test for olfactory function. So olfactory tests are helpful in confirming the diagnosis of anosmia and determining the degree of olfactory dysfunction as well as for follow-up. Anosmia incidence among patients with COVID-19 vary throughout countries, as reported in about 30% in South Korea to about 88% in Europe. As reported in Juan et al., the analysis showed the pool incidence of anosmia was 45% of total COVID-19 patients included in their study. The anosmia has sudden onset and recovered in less than 1 month in majority of patients. The pathophysiology of anosmia is not yet well understood, and the human coronavirus can reach the brain through the olfactory bulb, leading to inflammation and demyelination. So SARS-CoV-2 can cause same change in olfactory bulb when reaching it. MRI of the brain is the imaging modality of choice for picking up these changes, which would further help in better characterization and understanding of pathophysiology. So we do a systematic review where executed follow preferred reporting item for systematic review and meta-analysis PRISMA reporting guidelines. And we use the search strategy in most of databases such as PubMed, Science Direct, with the Midline and MPage. Then we do the processing for all the results we found. We remove the duplicate and we screen the relevant study for the further information. We have included English and published study reporting data sufficient to evaluate the olfactory bulb using MRI in our patient with anosmia. And the study with insufficient data or pediatric study or postmortem study, animal studies, review articles, editorial, proposal, and letter to editor, opinion not containing the original data, and abstract only were excluded. Then two independent reviewers screened the title and abstract for retrieved articles for potential inclusion. And we use the consensus by the third reviewer to address any disagreement between two reviewers. Then two independent reviewers claim that all retrieved articles for full text for possible inclusion. Then we assess the quality of the paper and we extract the data by two independent reviewers using Newcastle Ottawa scale for observation case control, Axis tool for cross-sectional, and quality assessment tool for case report or case series study. Then the article will be considered of good quality if it is scored 50% or more using an arbitrary cutoff. Then two independent reviewers extract the information from each included study and we use the Microsoft Excel in the extraction process. So with the main results, we find the study characteristics. Our search brought about science direct midline respectively. Study characteristic in do you hear? My voice is clear.
Yes, it is clear.
So this diagram shows the identification, screening, eligibility, and the finally included study. Article identify it about 138 through searching in database, and one article identify through additional resources through snowballing. Then after remove the duplicate, the article are found to be 107, and we do title and abstract screening, and we exclude about 48 of those paper, and after we do the full text screening, we exclude about 50%. So we just included 9 paper in the evidence of synthesis. The studies were from Europe, Asia, Latin America, and US. Most of the affected patients were young, about 19 to 63 years. A number of females are higher than males. And when the olfactory test when done in some study. This table shows the main characteristic of the paper that included. We include the gender, age, patient with anosmia, country, state design, and how they confirm COVID-19. We found the time of MRI question and duration of the anosmia varies between included study. Some study had MRI in first weeks from onset of anosmia, and other in months later, like persistent anosmia, or after partial recovery from anosmia. The duration of anosmia also vary. Some cases had long duration or resistance, by others while other had short duration of anosmia. The main MRI finding we found include signal hyperintensity, atrophy in most of them are normal. And when in a normal olfactory or pulp diameter described in table 2. So the MRI finding mainly are signal hyperintensity and atrophy. Some of them we found normal olfactory pulp, just in one case. This table shows the distribution of olfactory pulp size among male and female. So in male subject less than 45 years old, it should be more than 59 millimeter cubic. If more than 45 years, it should be 52. In female, more than 45, less than 45, it could be more than 54, and in female more than 45 years old, the olfactory pulp size are more than 43 millimeter cubic. This table summarize the main finding of our result, and I will highlight just a few of them. The first paper, Altudang et al. Find the MRI finding right olfactory pulp volume and the minimum and maximum median and the left olfactory pulp size. So we summarize that it have hypertrophy of the olfactory pulp. In discussion, we review the brain MRI olfactory pulp in patients with anosmia due to COVID-19 in 9 studies. Younger people or female are more likely to have olfactory dysfunction. This is consistent with finding reported in Lee et al. Study. The most common finding are hyperintensity and atrophy. In addition, enlarged deformed shape of olfactory pulp and shallow sulcus we also observed in few patients, with the exception of one patient who had normal MRI. While in some studies no clinical testing for anosmia was done, this may contribute to missed patients with anosmia whose anosmia went unnoticed. This is possible presentation of anosmia to go unnoticed as reported are harmless et al. We observed that patients who had MRI at earlier onset of the anosmia show enlargement and hyperintensity. An enlargement indicates edema and hyperintensity indicate microbleeding in some cases, while those with MRI done at later onset had atrophy, which may be speculated of the course of changes that occur in olfactory bulb. In upper respiratory tract infection due to other viruses, the cause of anosmia is obstruction. As reported in Al-Tudak, et al., and Kendrick Malley and Polita studies COVID-19 patients, they have excluded other cause of mechanism of anosmia, such as mucosal congestion, nasal obstruction, pre-existing taste and smell changes, head injuries, allergic rhinitis, and chronic rhinosinusitis. This finding delineates that injury to olfactory bulb is sensory neural and may be caused by direct ingress effect of the virus or secondary to inflammation process triggered by the virus. This is supported by the finding from Albert Hani et al. Study. The virus makes its way to olfactory bulb through the olfactory nerves, and these findings demonstrated in mice. We conduct this study according to PRISMA guideline, and up-to-date search of this first systematic review on olfactory bulb changes in the brain MRI in adult patients with anosmia due to COVID-19. But we have some limitation. Finding of this study required to be interpreted in context of some limitation. Firstly, no series of MRI done along the course of anosmia to capture all changes that occur in olfactory bulb. Secondly, the systematic review includes some case reports and case series studies, which are low evidence studies. Thirdly, with the exception of two studies, neither baseline MRI nor post-infection MRI were done to compare and evaluate the normalization of olfactory bulb. Finally, we included only published paper which might have introduced some publication bias. Our recommendation, clinical assessment of anosmia with olfactory test should be considered. So furthermore, larger study with some series of good quality MRI before and throughout the course of anosmia until recovery from infection or recovery from anosmia despite negative tests for COVID-19 ever longer. I wanted to characterize the better understanding of olfactory changes on MRI, so as the pathogenesis in patients with anosmia due to COVID-19. In conclusion, the systematic review found that most common changes in olfactory bulb in brain MRI are atrophy, hyperintensity. So furthermore, few cases show enlargement of olfactory bulb and others show change in bulb shape and shallow sulcus. Thank you.